With this week's Cardiology Countdown, we have two device therapy for heart failure and a very intriguing vaccine. So beginning at the number 3 spot, we have a small study that looked at the use of an influenza vaccine to prevent myocardial infarction. This was a study of 439 patients who had just been admitted with an acute coronary syndrome in the last 8 weeks, half of whom got vaccinated and then followed for a year. And total cardiovascular events, including death, MI, unstable angina, hospitalization for heart failure, stroke, were significantly reduced in the 220 or so patients who had been vaccinated as compared with those who had not, a rate of 9.5% versus 19.3%. The adjusted or unadjusted hazard ratio was 0.7. So this is a small study, but a randomized one. There was a prior randomized study that also showed benefit, and observational studies showing benefit. And so this has been a recommendation and a performance measure of giving vaccination post-acute coronary syndrome. I think the evidence base is still modest, so it would be ideal to have a large randomized trial of flu vaccination to see whether this could in fact help prevent myocardial infarction. The notion could be either infectious etiology or avoiding periods of secondary myocardial ischemia when people go through the flu. At the number 2 spot, we have an interesting subgroup analysis from the MADE-IT CRT study looking at the benefits of CRT, or cardiac resynchronization therapy, in heart failure patients that was seen to be greater in women than in men. They looked at the primary endpoint of death or heart failure and found about double the overall effect with a hazard ratio of 0.31, or a 69% benefit versus about half that in men, with a significant interaction p-value. Looking at death and heart failure alone, and also echo indices of improvement in LV function, all were apparently better in women than in men. Now, this is one subgroup analysis, and the women were more often those with left bundle branch block, and so that may have been part of an explanation. But certainly, any worry that this therapy might not work in women is clearly not founded, and this works as well, at least, and potentially even better in women with heart failure. The number 1 pick I chose this week is a cross of imaging and the use of ICD therapy, where a prospective series of patients had cardiac MR to look for late gadolinium enhancement, and that is myocardial fibrosis. And what was seen is the use of the presence of late gadolinium fibrosis for whether shocks occurred during the approximate 2-year follow-up. And there appeared to be a very clear relationship in patients who had late gadolinium enhancement of a greater number of shocks. And interestingly, of those with a non-ischemic cardiomyopathy with evidence of fibrosis, they had the highest rate of shocks, 29%. Those with ischemic cardiomyopathy, it was 14%. And the non-ischemics without late gadolinium enhancement had no shocks during that follow-up period. So this suggests they're very low risk, and could they potentially avoid the need for an ICD implantation? So an intriguing finding that I think deserves further work to try and sort out whether this CMR imaging could help target ICD therapy to those who need it most and avoid it in those who might not need it. So with this week's Cardiology Countdown, I'm Chris Cannon.